there are a couple of good questions that have come in. The first question is, I would change my urotomy pouch every 7 days. I've had no problems with leaks or other similar problems. Is there any reason not to use a 7-day routine as long as the pouches are not causing wearing problems? So Dr. Schuckman, what do you say to that so others would know about that?
Yeah, patients ask all the time about the frequency with which they need to change a pouch. And I think just to set a bar, the average is probably twice a week. So I would say most of my patients say, I just change it on like Tuesday and Saturday. And that's when my daughter comes over and helps me or whatever it is, or that's when I do it. I certainly have patients who wear their pouches longer. If you're not having problems, I don't think there's any medical reason why you need to change your pouch more frequently. The main reason people change them at that 3 to 4 day interval is because if they don't, it'll start to leak, or they're not confident that it won't leak after that time. I personally, I think if it's working for 7 days, you're not having skin problems and it's not leaking, it is probably just fine.
Yeah, I certainly, I think definitely that, if it works for you, then I think it's very acceptable. But in general, I think if one looks at the Wound Ostomy and Continence Nursing Society, or the WOCN recommendation, the recommendation Dr. Schuckman points out is every 3 to 4 days. And that's really to prevent against skin breakdown that can occur. So use of adhesives and the wafer starting to saturate urine under the wafer. Some of the preservatives start to get eaten away at when the pouch is on too long. So I think really the recommendation is, it's really for skin health. But if your skin health is good and you're not suffering from urinary infections, which is another reason to potentially change your ostomy appliance twice a week. So if you're having no downstream effects of keeping it on for a week, I think naturally it's very acceptable. And I have many patients who also adhere to the 1 week policy and not every 3 to 4 days. But again, I think that's a very fine balance. It's very specific for a given individual, whether you should be, whether it's acceptable to do it once a week.
Okay, great. Let me get to another question then, because we have quite a few. Is there any recommendation to avoid urinary tract infections as far as rinsing out a night bag with water Clorox solution, or even a rinse of the pouch on a regular basis? Or is it best not to bother with those things and there's not a whole lot you can do? And what other kinds of things can patients do for all types of diversions in terms of diet and fluid intake to reduce their risk of developing urinary tract infections?
Yeah,
I know you mentioned that a little bit in your slide, but if you could recap, that'd be great.
Yeah, I think that's such an important topic. So I think the starting point is hydration. I think that's very important, to really try to minimize the large count of bacteria that exists in the diversion, so to dilute it and to reduce the concentration of the bacteria. So good hydration is good. Nutritional aspects, certainly it doesn't hurt, the strength of the medical evidence that having specific types of nutrition or certain diet reduces the risk. I think we'd be hard pressed to knowing that, but I think a very healthy diet obviously builds immunity, builds strength, provides good nutrition to the body. These are all things that are helpful for our defense mechanism. So I think that's a very important point. Cranberry juice is known, in many fields of medical practice, whether you have a diversion or not. Cranberry does change the concentration of the urine and can reduce the risk of urinary infection. So I think these points are important. Changing your appliance in a structured manner on a specific routine, so 3 to 4 days, is important if you're getting infections. That nighttime bag, changing your bag once a week, the nighttime bag, I know that's a recommendation of WOCN, and they do recommend cleansing your bag with the product that was mentioned in the question, that it is a good way to cleanse your bag. So I think many of the points were brought out in the question itself, and the points you brought up, Stephanie, I think we certainly all endorse them as all techniques to try to reduce your risk of infection.
Mm-hmm.
We
Okay,
could
good.
probably
Thank
address
you.
a few others that I thought of while you were talking, Dr. Pohar, as well. And I'm curious for Linda, with the Indiana, if you've ever really had problems with recurrent infections. We sometimes have to change from, like, we routinely tell patients they can use the same catheter over and over again if they're catheterizing, whether it's a neobladder or a continent cutaneous diversion. But if that's not working, then another technique is to change to single-use catheters that you throw away, or more routinely irrigating a neobladder. You know, we don't always ask patients to irrigate long-term, but if infections are an issue, we may ask patients to do that.
Okay, this is all good information.
I haven't had any urinary infections, and I reused the catheter. But when I first initiated, got education about what to do, I use a Dial antibacterial soap, and I wash the catheter, and then I use hot water and kind of make it go, and then I air dry the catheter in between a towel. That was what I was told to do, and I do that pretty religiously. And I always wash my hands before I do the catheterization with the antibacterial soap.
Okay, good. All right, it's really helpful information. Obviously, when people have bladder cancer, they're going to continue to have a relationship with their providers. And there's a good question in here. I always wonder, when I'm asked to give a urine sample, would I give it from a clean bag, but tell them it's from a urostomy? But I've heard people say it's done differently. Please explain what is best when you're asked to give a urine sample. So either of you.
I can give my 2 cents on that first. So like the thing that drives me probably the most crazy as a urologist is when patients who have ileal conduits come in and they say, oh my gosh, I've been on antibiotics like 5 times since I've seen you last. And I say, well, have you been sick? And they say, no, I'm totally fine. My doctor just keeps sending urine cultures and they keep being positive. So many of those cultures get sent just from the bag. And, to me, to be very graphic, I feel like that's kind of the same as just sending it from the toilet water. That's not a sterile environment. And I do not treat infections, based on that kind of culture. So for somebody who has a urostomy, if we really need to determine what is going on, I like to catheterize the stoma and drip a culture into a sterile cup and really do that in a sterile fashion. And most people who aren't urologists aren't going to ever do that. Now if you're in a situation where you have a fever or symptoms and you're sick and your doctor, needs to put you on some antibiotics and sends a culture in another way, by all means, accept the treatment. But otherwise, if you're asymptomatic, I think that trying to collect a cleaner specimen is probably more efficacious. So you're not on antibiotics unnecessarily. And I'm very passionate about this, so I apologize for being so passionate about this.
Yeah, and the other
good
thing,
answer. You certainly explained it, I'm sure.
Sorry, Stephanie. The other thing I think is another practical point, though, is another way to possibly get a better sample is, if the individual can change. So if you can change your own appliance in the physician's office, if you have a spare with you, or you bring it, and you could put a clean pouch on. It's a little time consuming and just wait. That's another way to sometimes help the doctor out too. If you're not in a urologist's office, most doctors' offices are not very adept at changing your appliance or what to do, but certainly you might be able to help that situation.
Very good points on both. And I will definitely think of that in the future as far as, yes, if you're getting a sample from the bag, it's like taking the sample from the toilet bowl, and it's going to have other issues. That was definitely something that will stick in everybody's mind because it's stuck in mine. Here's another question. I was hospitalized 2 months after surgery with bacteria in my blood resulting in sepsis. Will I be more prone to this in the future? Is this something that you see commonly, or is this something that's more of a rare situation?
Well, I think the starting point is, it all evolved from the topic where we're having some dialogue about. It's a urinary infection. So unfortunately, the urinary infection got so severe it entered the bloodstream. So hopefully it won't happen again. but I think it's important, that be investigated. Are there any underlying influences of the diversion that can be corrected to preventing another severe infection? So are there any stones? Is there any obstruction? Some of the points, that were on a couple of the slides. So I think it's prudent to look into some investigation, but fingers crossed, hopefully it won't happen again. But unfortunately, there's no guarantee. Any urinary infection, there's a potential it can lead to this sepsis and blood and bacteria in my bloodstream, unfortunately.
Oh, thank you. Here's another good question. Are there any available things you can do to help for excess mucus and plugs that cause difficulties within neobladder? But just in all the diversions, are there any things that you see that work for patients in terms of diet or hydration that help to reduce problems related to the mucus that's inherent in using your intestines for getting urine out of your body?
Yeah, this has come up, I think, kind of all the time when we talk about this, because it's patients always are worried that something's wrong if there's mucus. So I guess I'd have two parts of this. One, mucus is a normal and healthy part of a urinary diversion. So seeing some mucus in the bag or in the toilet is normal. If it's causing problems with obstruction, the first solution is hydration. The more urine you're making, the more dilute that mucus will become, and the less likely it is to cause a mucus plug. Two, if you have a neobladder and it's really a chronic issue, you may need to catheterize periodically and irrigate out the mucus. And some patients need to do this once a week, just to keep the pouch a little bit more mucus free. And three, if you normally don't have mucus and all of a sudden you're having a huge increase in the quality of mucus, that actually can be a sign of an infection in a neobladder. And so it may be worth a visit to a doctor to make sure you don't have something, like an UTI that can be treated with simple antibiotics.
Can I jump in real quick?
Yep.
With a neobladder, when you first have your neobladder, you do expel a lot of mucus.
Can you speak up a little bit, Eric? You're very soft.
Sorry.
You need to speak a little bit.
When you first have a neobladder, you do expel a lot of mucus to start with, or shedding basically from the neobladder. As the years go by, it lessens and lessens. So a new patient that has a neobladder now is probably going, what the heck is going on and how long is this going to go on? Now at the 5-year part, generally speaking, you see like a light silt at the bottom of the bowl at the most, except for myself, if I do any kind of heavy exercising, I go play a game of golf or something like that, I'll have a little more shedding, but nothing like within the first year or two. It really kind of goes away, especially as Dr. Schuckman has mentioned, you hydrate, you drink a lot of water. You cut back on caffeine, hopefully, so that way the water will take effect and actually rinse you out. But in my situation, now we're rolling into year 6, I only have just a light silt and an occasional strand or two, after going and doing some hard exercise. So for new patients, yeah, it's going to be a little upsetting. You're wondering what's going on, but as you get further into this, it will shed less and less and less, or at least that is my experience, and I believe it's the experience of most people I've talked to with neobladder.
We have a couple of questions that are related to peristomal hernias, and I'd love to get your input as the doctors. Have you found that hernia belts can help? Or is there anything that people should avoid doing in the sense of exercise, activity, or reaching or doing anything that they should be aware of to avoid or reduce the risk of developing a peristomal hernia that you've seen in real life practice?
As Dr. Schuckman's talk had pointed out, peristomal hernias, they can be common. So they do occur. And a hernia belt is a wonderful option. I have many patients of mine in the practice, a hernia belt or an abdominal binder, to help whether they feel it's disfiguration or there's just a bulge or they have some degree of discomfort over that area, or as the question asks, with activities, they find that becomes more bothersome. A hernia belt could certainly help fix a lot of those problems. And I would certainly advocate that and encourage that if someone is physically active, exercising, or doing other activities, a hernia belt is a very good solution. And I wouldn't suggest that it should restrict your ability to do whatever you want in life. A hernia belt, I think, is a great solution and can help you, achieve what you want to do. Weight gain, unfortunately, which is hard for all of us sometimes, to manage our weight, but weight gain can be problematic, with peristomal hernias and exacerbate them. So trying to manage weight to the best of our ability, that can certainly sometimes be helpful.
Mm-hmm. Schuckman, did you have anything else to add?
Not a lot else to add. I mean, we talked a bit in the talk about sort of prophylactic techniques. We use hernia binders. We use abdominal binders routinely after surgery. We have patients wear them for several weeks. And just for patients who are suffering with a hernia, many of the supply companies do make what's the word I'm looking for? Individually sized pre-cut hernia binders with the hole for the ileal conduit. So customized is the word I'm looking for. So you can send in your measures. And I think that there's a company called New Hope that makes those. And many patients just find they give extra support to the area, certainly. Most patients don't come to having surgery for a peristomal hernia. For most patients, they live with the hernia and manage it conservatively. I think patients who we end up kind of deciding to do surgery, it's a big deal and patients know that. And so it's usually for patients who are really having problems with bowel obstruction related to the hernia, which can be a complication, or they just simply can't fit the appliance appropriately on their because of the hernia on their stoma.